very interesting thing is that the CLEOPATRA regimen, you do the chemotherapy only for a short period of time, and then you continue with the maintenance that doesn't have chemo, only HER2-directed therapy. Whereas the two other arm with T-DXd keeps on going. We don't stop. We don't know the results. We're anticipating it's going to be a positive study because we know T-DXd is more powerful than chemotherapy. What do you think about the study design? About this one of them you stop short, whereas the other one you continue? And even if it's positive, do you think that people are going to adopt it? Or do you think they're going to wait for it to be used in the second line?
So let's first say, I think it's going to be positive.
Yes.
Just because, as you said, T-DXd works better than chemo, especially T-DXd indefinitely compared to chemo for a short time. And I will say the CLEOPATRA regimen is kind of an anomaly in breast oncology because usually we do not stop drugs if they're working. And I think this is something that we need to do because taxanes are amazing drug that they work very well, but have this issue that after a while they cause unbearable peripheral neuropathy, and so you have to stop. It's not a choice. T-DXd doesn't have this. You have patients that can get it for years and keep benefit from it without having more side effects. And so I think potentially the fact that you can give it indefinitely is a pro, because if you can keep the tumor under the pressure of chemo while maintaining a good quality of life for a long time, it's a good thing. That said, we know that some patients may not need that, because some patients, you can give this intensive chemo for a while and then they can remain on HER2 blockade for years without progression. The issue is recognizing those patients, and right now we don't do that. We use CLEOPATRA with the maintenance HP for all of them because it's what we have. So I think in the future what's going to happen is that if the trial is positive, and I think it's going to be positive.
I think so too.
One of the two are. I think the pertuzumab will add something, especially later on, not in the first phase, but later. Physicians will figure out how to maybe reduce the dose, and then at a certain point, maybe after many months or maybe years, stop it at certain points. I think it's going to become very artisanal, just because you cannot replicate exactly what the trial did with the reduction criteria of the dose according to the trial. I think we're just going to be doctors. We're going to figure out how to best use the drug, and for patients that seem to need more, I've got maybe very aggressive disease that doesn't respond perfectly, maybe you keep the patient on for a longer time. But if the patient after 6 months or 8 months or 1 year has got a complete response of disease and has got some side effects, well, maybe you start reducing the dose, and if it's not enough, maybe you even stop it. So I think we're getting there, but what we really need is a biomarker telling us that, and we don't have that yet.
Thank you. And that's why oncology is still an art. That's why you're irreplaceable. AI will not replace you. Remember that. But you're totally right. We need a biomarker. We need something to let us know, am I going to be okay just doing the CLEOPATRA regimen, or should I go more aggressive and using T-DXd? Or even better, is there a biomarker that tells me I'm okay to give a holiday from T-DXd? Because the chance of ILD doesn't stop early on. It's not front-loaded. It doesn't. ILD, the risk of ILD is sustained the more you give it. It's not going to stop. Like if your patient did not get ILD in the first 8 or 9 cycles, doesn't mean they're never going to get it. There is always a risk of ILD. And that's something that worries me, because let's say your patient got a complete response, yet you keep on going, and then they got this ILD. That's it. This drug is gone. It's gone from your arsenal. So in the future, if you need it, you cannot use it. But how about if you got a CR, like you said, maybe you can switch to something else. It maintains HP at that time. And in the future, in case the cancer came back, they can reintroduce T-DXd and restore disease control. What do you think about that?
Well, I think that I'm very glad that there is a trial already start enrolling that is looking at this, the METER trial, that basically gives induction T-DXd for, I believe, 6 to 8 cycles, and then starts maintenance HP subcutaneously. And I think it's going to be an important trial. It's a single-arm phase 2 trial, so it's not a randomized. It's not going to give us perfect evidence, but at least
some evidence.
It's some evidence. And then what they do is that if the patient progresses, the physician has the option to reintroduce T-DXd. And I love the idea, because if you can use this highly active drug for a while, and then you stop, and then if needed, you use it again, and then stop. Maybe in this way, we can limit the resistance acquisition from the tumor. Not that we are sure, maybe we're doing the opposite, but this trial is going to test that, And I think it's gonna both DESTINY-Breast09 and the METER will give us a way to utilize T-DXd earlier in patients that may derive some benefit from it, and maybe cure more patients. I feel this is an important thing in HER2-positive metastatic breast cancer. Sometimes we see super prolonged disease control for 8 years or 10 years or more. Some patients seem cured. Can we increase the number of those patients?
Here you go. You heard it first here. Curing metastatic breast cancer. We are getting close. Love it. Love it. Love using that word.